If you need any help with your seatbelt, please see your flight attendant. Now we're getting on to connection, function, and aesthetics for complete care. Little rundown on our panelists tonight. Leading off is Dr. Leonard Hess. Lenny, as I like to call him, is the clinical director here at the Dawson Academy. I've known Lenny for a long time. Both he and I have been at the Academy for well over, well, it's quite a long time. He joined in 2009, his undergraduate at Indiana, and of course, he went on to bigger and better things at Northwestern University. Lenny is a private practitioner in addition to teaching a lot of the core curriculum here at the Academy, and he can be found at mycharlottecosmeticdentist.com. Welcome, Lenny.
Thank you very much, Greg. Appreciate it.
Next up, and in no particular order, Dr. Neeraj Khanna. Neeraj is near and dear to my heart because Neeraj came on board about the same time I did through the program. So I saw him at one of his first Dawson Academy courses way back when. He is a Canadian, and he is now an American. So we talk a lot of hockey in our spare time. He also wrote this book, which is a shameless plug for him. We'll put that in the chat for you. But everything that he ever learned in the Dawson Academy, he put into a book for us, and I enjoy it. It's on my bedside. Neeraj is absolutely one of the best faculty members that I have from a personal experience, the way he's gone through the curriculum and all the trials and tribulations, and he's emerged to be the man he is today. And I'm just proud to have him here, and he's a wealth of information for all of you. So tag him as you can. Neeraj, welcome.
Thank you, Greg.
Lastly, Dr. Shannon Johnson. Shannon is a near and dear. She was actually one of the first residents I met when I started the Academy at Seminar 1 way back when. I've watched her grow up in this philosophy, cut her teeth as you will. And she hosts webinars with me once a month on our association webinars for our members. We cover a lot of ground in those as well, but Shannon is a private practitioner. She also helps assist at a lot of our courses. She's an associate faculty member, and you can find her at shannonjohnsondmd.com. She is also running 2 of our study clubs, and she's from Kentucky. So Shannon, welcome.
Thank you. Thank you. Happy to be here. Thrilled, actually.
All right. I'm going to get out of the way now because that's it. They don't want to hear from me. So y'all take it away, and I'll be sitting here in the background. Ask your questions in the Q&A. Lenny, it's your show.
You got it. Thank you very much, sir. Well, hey, everybody, welcome this evening. We always appreciate it when everybody's willing to join us and give us a little bit of their personal time to grow as a professional, and to always, it's always great to have some camaraderie among dentists as well. And, you know, the Dawson Academy, we always like to say that when you start to take courses from us, you're part of the family. So we always like to get together and have some little family gatherings here from time to time. So what we want to talk to you guys about tonight is actually a very interesting topic, because it's the merger of aesthetics and function, or the merger of aesthetics and occlusion. And what you've probably figured out if you've been a dentist long enough and you've dabbled in and tried to dive into the deep end of the water sometimes on some of these challenging cases, is that sometimes things can go sideways. But what we want to do is we want to give you guys a little glimpse of the predictability that can be gained by learning to become a complete care dentist. And when we talk about becoming a complete care dentist, what we talk about is having a good understanding and the ability to diagnose the entire stomatognathic system, from the joints, the muscles, the back teeth, the front teeth, and how those 4 components, those 4 circles, which are the 4 circles in the logo of the Dawson Academy, how those things all are interrelated. And so when we talk about aesthetic dentistry, well, what we all know is that most of the time we end up building our reputation with our anterior dentistry. And there's a lot of beautiful cases out there that can sometimes be amazing before and afters, that can seem very simple, and you can do veneers and everybody is happy, and you can crack a bottle of champagne on your patient's head and celebrate the success that you had. But where things sometimes go sideways is when you see patients like this. And you look at somebody that has, in a very short period of time, before the age of 50, you know, they have managed to destroy their dentition. And these are the types of patients that can sometimes be very challenging for us as restorative dentists, because these are the people that like to break dentistry. If they've been able to figure out how to destroy their own dentition, then chances are they're going to be pretty good at destroying what we put into their mouth. And so what I want you to think about is what are all the different things that we can change and affect when we work on anterior teeth. So let's just imagine for a second that we're going to restore even 4 or 6 maxillary anterior teeth. And I want you to think for a second of all the different things that we can affect. So obviously we can affect the aesthetics. We can oftentimes affect the phonetics or the speech of our patients. We can change the incisal edge position, both vertically and horizontally. We can alter the maxillary anterior occlusal plane. We can alter the centric stop, or where the mandibular teeth are touching the linguals of the maxillary anteriors, which means that we're altering envelope of function, anterior guidance. So one of the scary things is when we start altering anterior teeth, what are we doing is we're altering pretty much everything that we can change for a person. And so a lot of times we look at sometimes anterior aesthetics as sometimes being very sexy and predictable, and it's not that complicated. We're not dealing with the tongue, and the bite sometimes can be easy to adjust in these. But in the grand scheme of things, when we start managing the aesthetics for our patients, there is an enormous amount of things that we can change in there. So it's our responsibility to determine, well, where are these teeth going to go in space? And what we mean by that is 3-dimensionally. Where are we going to vertically and horizontally position these teeth so that they can be not only aesthetic, but also functionally phonetic, or functionally successful, and also phonetically successful? We have to decide what materials we're going to use and to what functional relationships are we going to place them in. Maybe specialists will need to be involved in sometimes in these cases. And really, it can sometimes be a very overwhelming challenge that we get ourselves into. And really the biggest thing that we need to remember and to consider is remember that teeth are only part of the system. And a lot of times the way we were trained in dental school is we were trained just to look at teeth as individual problems and kind of solve them, from what's worse to what's better, or go in a sequence there. But remember that teeth are working within a system. And a lot of times when you really think about it, these types of patients, when they walk in the door, can be very challenging. And so let me bring Shannon and Neeraj into this. And so as you guys being highly trained complete care dentists, when you see a patient like this walk into your door, what are you guys concerned about when somebody comes in? And a lot of times what's scary about a lot of these patients is they don't necessarily come in complaining of pain. They don't really come in a lot of times having anything really as a chief complaint. But what are you guys concerned about? Because overall, that's the number one thing that we always have for our patients is concern.
Shannon, after you. Ladies first.
Well, so when I see someone who walks in like this, I worry about where their dental health is going to go for the rest of their lifetime. We talk about creating mouths that are beautiful and functional, but one of the other big key points is that it's maintainably healthy, right? And so when you see someone who already has a ton of, class 5 restorations and incisal restorations, I worry significantly. So with that patient, I already start discussing the concerns that I have, like right off the bat. I hand them a mirror and I start talking. Obviously we've got some biological issues. There's going to be some functional issues. I look at airway, tongue thrust. There's 1,000 things that would pop into my mind, which then I have to put on like my Sherlock Holmes hat and become an investigator and do my exam and figure out really what we need to take care of. So that's
Neeraj,
kind of my thoughts.
how about this patient? If I show you, if this patient walks into your office, Neeraj, what are you worried about here?
Well, it's you've got some chemical erosion going on. You have to look at the medical history. You've got to ask questions, and I think that's one of the things that I learned the hard way is to ask the right questions for these people, because like Lenny said, a lot of these patients don't understand they have problems, and until you ask the right questions, that opens the conversation, open-ended questions. Well, Mrs. Jones, are you aware that you've lost a lot of the enamel on the inside part of your teeth? Has anybody explained this to you? And have you noticed anything that you could share with me? And that opens another avenue of what are the patient's expectations? In other words, they're coming to see you, whether they are aware of the problem or not, but what is it, once you make that problem apparent, what are their expectations? In other words, is this important to them? Are they interested in solving these problems? And that's something that I used to struggle with many, many years ago. And it's gotten a lot better now, but there are some patients who will walk into your practice unaware of these problems because the last 6 dentists said everything looks great.
Yeah.
And that poses another challenge for complete care dentists.
Yeah. Absolutely. One of the frustrating things is, you look at all these patients, and you guys remember there's that article that came out in Reader's Digest, like, I don't know, maybe it was 7 or 8 years ago, where their criticism was that they took patients to different dentists and they were complaining about different treatment plans that they were getting sometimes. And that the focus of the article was the thought that dentists are over treatment planning and they're trying to do too much dentistry. I'll be honest with you, if anything is the case in America today, is that we are under treating our patients because there are so many patients walking around. So if you look at this patient right here, and you can see that there's some issues going on there. You look at the canine. So if I kind of bring my cursor over here, I want you to imagine how much tooth structure has been lost on this canine for it to get worn that bad, and to where you start to get wear into dentin. And look at the lower anterior canines, the mandibulars and the mandibular anterior teeth. You have all this wear into dentin, but if you look at the linguals of these maxillary anterior teeth, a lot of times these patients come in and what do they want? They want veneers. They want their smile to look better. They realize that their teeth are maybe getting a little shorter. Maybe they're chipped looking. They're looking a little bit aged. And I'll tell you what, on this patient, if you were just to look at them and think, okay, well, I can do veneers on this patient. And if you don't understand why is this patient getting this type of wear on the linguals of their maxillary anterior teeth, listen, you better hope that patient is single because the two of you just got married, because that patient is going to be spitting porcelain back at you every single time you see them, and they're going to be in your chair a lot of times. And so, you look at this, and I want everybody that's on this webinar right now to think about how many patients do you have in your practice right now that have incisors that look like this? And right now you can probably literally think of hundreds of patients that you see every year that have these types of problems. And if you look where my cursor is, this patient right here, believe it or not, this patient's about 28 years old. But if I didn't tell you that you looked at those lower anterior teeth, you would probably think those are the teeth of a 70-year-old. And so that's one of the big things that when we want to become a complete care dentist and we actually want to improve the health of our patients, and most importantly, get our patients to maintain their health for their entire lifetime, is one of the changes that we have to understand is that we have to start thinking about dentin being exposed in the mouth is no different than an open wound at any other part of the body. So remember that dentin is the inner layer of the tooth, not the outer layer. It's only half as hard, half as calcified, and it wears away 7 to 9 times faster than enamel. And so, the question you ask is, are these incisal edges working for these patients? And the answer is no, it's not working for these patients. And are they going to get better or worse? They're always going to get worse, right? Thank goodness I've never seen a tooth spontaneously heal itself yet, right? But we have these patients in our practice right now, and what they have not been a lot of times given the option is to choose to do what's best for themselves, because these patients don't fall within the boundaries of the standard of care, which has been dictated by dental insurance. You guys agree?
Totally.
Yeah.
100%.
Yeah. And Lenny, if I could chime in real quick about this.
Yeah.
What you all need to understand is that Lenny brought a great point. All of you are seeing these patients already. The question is, what are you doing about it? Are you comfortable with treating these types of problems? And that's what I have heard for over the years, that many dentists see these problems. They just don't know what to do with them, because if they slap composite, they know it's going to fail. And I wanted to bring that point because it's many of you out there now already know that this is what's going on in your practice. And I want you to understand there's a better way to do this. There's a very predictable way of solving these problems.
Absolutely. So, I always say that we have to be really good at asking one question. And that question is why? Why did this happen? We've got to be good at asking these questions. However, the bigger challenge is we have to become an expert at answering that question. Because when we have these patients with worn dentitions and worn teeth and chipped incisal edges and wear into dentin, is you have to realize that these patients now, their teeth are moving targets. And a lot of those patients, when we were showing that one patient, the occlusal shot where all the wear was into dentin, remember when these patients are still biting into their maximum intercuspation, their teeth are still touching. Well, I want you to think about the volume of tooth structure that needs to be lost for you to get into dentin on the linguals and maxillary anterior teeth. And if those teeth are still touching, that means they have changed position. And that's how a lot of times these cases can sometimes be very difficult to manage. And especially if you don't understand the difference between centric relation and maximum intercuspation. And so what we like to talk about at the Dawson Academy is getting a grasp and understanding of occlusal disease. And here's what's crazy about occlusal disease. It's the most common dental disorder, the number one contributing factor leading to eventual tooth loss, the number one reason for needing extensive dentistry. Remember, all these patients that we're showing you that you guys all have in your practices right now, a lot of them at one point in time were 22-year-olds that were starting to show very early signs and symptoms of where they were going to end up when they were 40, 50, 60 years old. And really what our responsibility is as a dentist is to learn how to diagnose better so that we can catch these patients earlier on so they don't need extensive dentistry. But occlusal disease is the number one factor associated with discomfort within the masticatory system, the number one factor of instability of orthodontic treatment. I mean, think about how many patients you have in your practice that have orthodontic relapse. Well, a lot of that is because of occlusal disease. The number one reason for tooth soreness and hypersensitivity, the number one most common reason leading to a misdiagnosis of endodontics. I mean, think about how many patients that people come in with a hot tooth, you send them to the root canal specialist, they get a root canal done, they come back in 6 months later, hey, my tooth still hurts. Oh, it's normal, it'll go away. A year later, my tooth still hurts. Well, guess what? It probably wasn't an endodontic problem, it was probably an occlusal issue. But here's the big disconnect between these two things. Occlusal disease is the number one most common dental disorder and the most undiagnosed dental disorder. And really that kind of falls back on us as dentists because we've really kind of fallen victim to the insurance game or the trap of standard of care, which has been dictated by the insurance industry. And so what's the problem when you want to treat occlusal disease or wear into dent, all these different types of things? Insurance doesn't pay for it, does it, guys?
It's something that it took me a while to figure out in the early days, Lenny, but insurance, that's a separate topic altogether. And don't get me started because it not only upsets me, but it upsets my staff every time insurance comes up. But this is the thing about insurance is that are they really looking at occlusal disease? No, they're looking at bacterial problems only. And that's it. That's what they want to cover. And that's what they will cover. It's up to us as clinicians to say, there's something going on that we need to address that will prevent more disease later on in the future. And so that's key.
Absolutely. So you kind of hit on a really good problem, Neeraj, is that insurance is a little bit of the problem too, but a lot of the problem is how we were trained in dental school. Because what were we trained in dental school? We were trained to treat bacteria that causes decay, bacteria that causes periodontal disease. And what do we know by most of our patients that end up having major problems in their mouth? Well, yeah, there are people that have bacterial problems, but a lot of them has to do with force and mismanagement of force and people suffering from occlusal disease. And that's a vast majority of patients that are out there. And we were really taught to go one tooth at a time. Well, solve this problem. And a lot of times when we were in dental school, if we had a patient that needed more than 2 or 3 crowns, they got pulled out from under us and sent to the pros department. And we never really learned how to manage these more complicated cases so where they can become predictable and profitable and fun. So when we talk about our patients that have problems, we talk about putting our patients' problems into buckets. And, we talk about what we were really trained to deal with bacteria in dental school, decay, periodontal problems, people with endodontic lesions. What we weren't really trained is to how to handle people that are having functional based problems. And these are the patients that are having what we call signs of instability, wear, migration, mobility, sore muscles and mastication, and patients that are having temporomandibular joint disease or TMD or breakdown in the joints. And a lot of dentists, when you start having a patient that is having TMJ problems, we just don't know what to do besides try to shove a piece of plastic in there and hope for the best. And, there are so many patients out there that have these functional based problems that end up leading to aesthetic based problems. But now we talk about a fourth bucket, which has come into the spectrum of dentistry in the last, I guess, 8 to 10 years, wouldn't you guys say? And that's airway. And now airway has become one of the hottest topics in dentistry. But really, when I look back and you guys share your experiences, what I've been in private practice now for 22 years, but my first 7 or 8 years in practice, we never mentioned airway within the profession. It wasn't even a consideration. But now what I realize is that most of my major failures and problems that I had as a dentist were directly related to airway issues. The patients that I couldn't figure out, how in the world are they breaking anterior teeth and chipping incisal edges? I mean, do you guys have any stories or experiences similar to that?
I agree with you, Lenny. Airway was not a topic of concern, but with airway coming to the forefront, it's something that we all, again, we can't diagnose sleep apnea, but we can look for signs. We can look for things that are suspicious for sleep apnea. It's a medical condition. We want to make sure that we recognize that. But yes, it has a huge impact on our outcome. And then the question then becomes is, do we manage the airway? What about all this restorative care? It's a very tricky balance. But again, here's the important part that I've learned in my practice is that, remember, these are problems that your patient owns. We don't own these problems. And if they're responsible for their airway, if they're responsible for keeping their mouths healthy, then it's up to them to make that decision. If they refuse to take care of their airway and your dentistry fails because of that, you have to make that clear to them. And I'm very concerned about this. But if this breaks, then I want you to understand that it's nothing to do with anything we've done, because we've stabilized your occlusion. We have fulfilled the requirements of a really good bite. But there's another element here that's causing stress in your system.
Yeah.
And that's what I've learned the hard way, Lenny.
Well said, Neeraj. If I can say that, you're talking about like a case. I can think of a case that began failing solely of airway issues. And this was a patient who had some dentistry south of the border that was really over-engineered. The teeth were about 12 millimeters thick, splinted together all the way around with base metal. It took multiple appointments to actually just section through the bridge. A lot of burrs and a lot of water and a lot of heartache. But anyway, so we had reconstructed her mouth. She wore a CPAP and had her airway component. I had the conversation just like you just said, Neeraj, like we have to maintain a happy, healthy airway. She had a splint. Fast forward 3 years, she was traveling a lot, started to not wear her CPAP, stopped wearing her splint. What do you think happened? We're all here. I'm just sharing with you. Things started cracking, breaking. Started with a single canine. Once one canine fell, just started going back. So, we went back, we redid work, we cut everything back off, we got her back to her sleep doctor, put her back in provisionals, worked through the whole case again, and did it again. And it was on her at that point, but you still feel bad. You hate to see things fail. And so, airway, huge.
You guys made a great point there. And Neeraj, you were talking about making sure that patients own their problems, right? And so what happens when you don't have the clinical skills to do a proper diagnosis is that leads to stress, and stress leads to fear. And fear keeps us boxed into a comfort zone within dentistry and keeps us kind of trapped where we are. Because when patients aren't educated to where they own their problems and they can't really understand the implications of their situation or understand the long-term effects of their choices, that can lead to problems. It can lead to failures. And the failure to diagnose, we have so many dentists that come to the Dawson Academy, and a lot of them, they come to us for 2 reasons. Number one, they come because they're burned out and they want to get out of the insurance game and start to treat patients more completely, more whole. And the second is the dentists want to learn to predictably do larger restorative cases. And, a lot of times they've been trapped either in the general dentistry side of fear or the large case side of fear where things started going sideways. And in dentistry, when we get stressed out, we get fearful. And it's just a really bad cycle that we get ourselves into. So the question becomes, well, what's being missed in most dental practices? Well, the good news is that we all have patients, but what's being missed in most dental practices is understanding a complete examination. I'm going to explain exactly what that means in just a second. But the other thing that's being missed is taking the information from the complete examination and using that to make a differential diagnosis and allowing the differential diagnosis to become the gateway for appropriate treatment. And that's really what we're after, is we want to always make sure we're doing the right thing, the ethical thing for our patients. We don't want to over-treat our patients, but at the same time, we don't want to under-treat our patients. So the question becomes, well, how do we start to control quality, and how do we make our anterior restorations, how do we make them predictable? How do we make them profitable? How do we make them look beautiful? And how do we make this become a really exciting part and profitable part of our practice? Well, the foundation of all that is the TMJ occlusal examination. And so when we talk about the failure to diagnose and how that leads to stress and fear, and how we make sure patients can own their own problems and make things predictable, this is where it all starts. And guys, why don't you share a little bit about how your practice evolved and changed, and the amazing things that happened once you guys learned how to do a complete examination. Shannon?
Yeah, so for me, it was really interesting as I started implementing the TMJ occlusal exam. I started connecting the dots, like you said, the why. You started actually to see that patient's first point of contact in centric relation, when you did the load test and checked for first point of contact, is actually the tooth that's been sore, that they've been complaining about sensitivity on for years in a chart. You start asking questions about, just a general history of the jaw joint, and it opens up a lot of conversations. It was just amazing to start to see that connection for me. With what I was seeing in the mouth. It was just mind blowing. And then once you see it, like you said, you can start to diagnose it. You can start having a conversation with the patient, seeing when they're ready. Then you can actually, if you're going to monitor and observe someone over time, you have tangible things that you're going to be observing over time. So you're not just watching things get worse or change and really have no reference point.
Neeraj, how about you, bud?
Yeah, so for me, two things. Number one is I thought I was doing a really good exam, to be honest with you all, before I met Pete Dawson. And I thought I was doing the best I possibly could. And when I learned about this process, I realized that this section right here was completely missing from my examination. And so as the years went on, I started becoming more comfortable. But like Shannon said, connecting the dots was my biggest challenge, because in my mind, I could connect the dots, but in my patient's mind, they've never had an exam like this before. And so how do they connect the dots? And that was my biggest struggle, because I know what to do, but they're not getting it because they've never had an exam like this. And then there was a period where, to be honest with you all, they were questioning my motives. I've never had an exam like this. What are you looking for? Why do I seem to have all these issues where no one else told me I had these issues? I struggled through that phase. And then I worked on my verbal skills. And now we're at a point where not only do I connect the dots, but I connect the dots with my patient. And so when they finish that exam, we both know the same problem. The only difference is I know how to solve it and they want to know how to do it. And that's the best way I can summarize it for you.
Yeah, we call that co-diagnosis.
Correct.
Right? So as we're going through every step of the complete examination, our job is to educate the patient. Well, what does normal and healthy look like? And if you don't draw that contrast between where they are and what normal and healthy looks like, they're not going to understand that. Because remember, if a patient comes in and they're not experiencing pain, they're going to typically always assume that whatever they walk in with is normal and healthy. And so when you educate the patient and you take them through this co-diagnosis, ultimately what we want to do is we want the patients to start to ask us one simple question: what do we do? And when a patient starts to ask, well, what do we do to get me normal and healthy? That means case acceptance has already started. So what we're really trying to do is we're trying to identify what's the weak link in the system. Is it the teeth? Is it the joints? Is it the muscles? Is it bacteria from the periodontium or decay? But remember, like, we've all had patients that come in our office, like a 22 or 23 or 24-year-old woman that comes in with beautiful teeth, but they're crying in my dental chair because they're having such bad TMJ problems, or they're having such bad occlusal muscular pain. And you look in there and sure enough, they have an anterior open bite. They had a history of orthodontics, and now their front teeth aren't touching correctly. And so we talk about what are called the 5 requirements of occlusal stability. And if they're not being met in the mouth, you're not going to have stability within the system. So the complete examination, what it allows us to do is to group our patients into two different groups. What we call general patients, where the size, the contour, and the position of the teeth is working out for the patient. And the way you know this is these patients don't have wear, don't have migration, don't have mobility. They don't have clicking and popping temporomandibular joints. They don't have sore muscles and mastication. And then the other group of patients is what we call specialty patients, where the size, the contour, and the position are not working out from them. And these are patients that show signs of instability, wear and dedentin, migration, mobility. They have clicking and popping temporomandibular joints. Think about that for a second. How many patients do you have in your practices right now that have clicking and popping TMJs? And the answer is probably 55 to 70%, somewhere around there. And what most dentists don't know is, what do I need to do for those patients? And they do need something, because healthy joints don't click and pop. And that's a big paradigm shift a lot of times. So one of the other ways that we make this differentiation between specialty and general patients is, well, they're going to be ones that want an aesthetic change. Because remember, when we were just talking about in the very beginning of this lecture, if we just work on 4 or 5 or 6 maxillary anterior teeth, we're literally changing everything to do with function, aesthetics, and phonetics for that patient. Everything is being altered. Patients that have signs of occlusal disease, patients that need extensive dentistry. Well, what's extensive dentistry? Well, if you're doing 3 crowns, if you're going to do a crown on 13, 14, 15, you're affecting 50% of the posterior occlusion. You better believe that's extensive dentistry. But in the reality, a lot of times, these patients end up having combinations of these. They have signs of occlusal disease, which have led them to want an aesthetic change. And as a result of that, they need extensive dentistry in there for it. So what really has to change in our practice is to be able to predictably and profitably manage these patients is we need to learn to do a TMJ occlusal examination, and we need to do what's called additional records. And what that means is be able to record centric relation, use an actual face bow, not what I call a fake bow, but a face bow. And there are 21 different photographs that we teach you to utilize in your treatment planning process at the Dawson Academy. But there is so much that you can gain by doing a complete examination. Am I right, guys?
Totally.
Neeraj, you kind of hit the nail on the head. Is you can separate yourself from other dentists, and you can gain expertise and credibility because you are treating patients in a way they've never been treated.
You know, Lenny, can I just say one more thing? I remember
Please.
Pete Dawson saying this years ago. And I remember when I took seminar 1 and Pete was doing the lecture, he wants us to think like physicians, right? Physicians of the masticatory system. So if you all think about how a physician works in their practice, you know, they see their patients, the patient has a chief complaint. The doctor does the exam first, orders lab results, lab findings, orders the testing, the x-rays at the end, compiles the data, comes up with a diagnosis, and appropriate treatment is rendered. This is what physicians do every day. But we as dentists don't behave that way. We actually do the opposite. And that's what Pete emphasized so much, is that when you understand this process, you become this physician of this system, and you handle it the same way. And that's what Lenny was saying, is that that's how you separate yourself, because not everyone does this. Whether they like it or not, it's a choice. And I'm telling you, this is the better way. Being a physician of the system, you own it. And that's the most amazing experience I've had with this process.
Yeah, so that what Neeraj is talking about is what we call the process of complete care dentistry. So the foundation is doing a complete examination. And when you find these patients that are specialty patients, we do the additional records. And then we have the information that we need to sit down and to 2-dimensionally treatment plan and solve the problem conceptually in our brain, and then 3-dimensionally treatment plan it either on an articulator or do it digitally. And that allows us to produce provisional prototypes, which allow us to control quality. And I'll explain what that means in a minute. And then those become the blueprints for our definitive restorations. But all of it really starts at that complete examination and making sure that we have these clinical skills, which are very learnable. But you just need to spend the time to learn these clinical skills so that we can figure out what the weak link of the system is. And the great thing about what we teach here at the Dawson Academy is that we have a wonderfully constructed support structure for whatever phase of dentistry you're in. We have an organizational checklist that guides you through the process to make sure that you don't skip steps or make mistakes, and to make sure you're always doing things in the proper sequence. So when you're conceptually working out what needs to be fixed or altered for a patient, we have this, what's called the functional aesthetic analysis. And when you're ready to transition into your three-dimensional treatment planning, we have our 10-step three-dimensional treatment planning checklist. When you move your patient into the provisional phase, we have our 10-step provisional checklist that guides you step by step. How do I make sure I can predictably adjust provisional restoration so that they're aesthetically beautiful, functionally correct, and phonetically accurate for our patients? And when it comes time to communicate with your laboratory technician, we have a laboratory communication checklist as well to give them all the information that they need to support you, to give you the results that you need. Because we all know that our dental laboratories, they either make us look really good or make us look really bad. So it's definitely in our benefit to give them as much information as we can to help them. Now, what's very interesting about our functional aesthetic analysis checklist is that it's broken up into 4 different components. And you'll see that the first component is in red up there, and it's all about the health of the temporomandibular joint. And what Dr. Dawson used to always say was that if this up here is not stable and healthy, anything that you do down here is not going to be stable and healthy. And that's why we always want to start by diagnosing the health and the stability of the temporomandibular joints. And if they're not stable and healthy, we can teach you how to predictably rehabilitate the joints to get them to the point where they're ready to accept restorative dentistry. Interestingly enough, after the joints, then we come to our 5 requirements of occlusal stability. And these are what I call the 5 commandments of a good bite. And this is proper function. And what we say is that proper form follows function. And so if you go to our next 2 steps on our checklist, you see the 6 elements of global aesthetics and the 6 elements of macro aesthetics, because it's very easy and predictable to make teeth look beautiful if you make them functionally correct first. Probably one of the most challenging situations in dentistry is when we make teeth look beautiful first, and then we have to figure out how do we make them functionally correct. And we got ourselves into that problem a lot in our profession in the 1990s when the aesthetic revolution was happening and everybody was getting diagnosed with acute porcelain deficiencies, and everybody needed veneers or everybody needed something by Ivoclar on their front teeth, and bonding was predictable and people were taking out home equity lines of credit to get 20 veneers. And what it did is it drove us back to the golden age of function and occlusion that we're in right now a little bit. But why don't you guys talk about a little bit how utilizing these checklists in your treatment planning process, how that helped you to get predictability in your cases?
I think for me in the early stages, even now I still use it, but in the early stages, it was something very methodical for me. And what I realized the hard way was, regardless of how simple or how difficult the case presented, going through this checklist, I always got the same result. That was the beauty of this whole process. In other words, what Lenny said earlier is that at the end of the checklist, you fulfill the 5 requirements of a stable occlusion. Now, when you figure that out on the articulator, you realize this works. Now I just have to present it to the patient and then transfer it into the mouth. And so for me, it's a great system. It's something that, people like checklists, Lenny, Shannon, everyone loves checklists. I mean, pilots use it all the time. Fire departments use it all the time. Hospitals use it all the time. There's no reason why we shouldn't use it here. And I think this has really made a difference between taking the guesswork out of everything versus having everything done predictably.
Yeah, Shannon?
So whenever we are looking at a complex case, Not even just an easy, but let's start with the complex. A lot of times we have that feeling of being overwhelmed. So, while they're in the chair, we've already been trained to try to diagnose what everything needs to happen. So when you start going through this process, I found it so freeing that you could take time to study what you're looking at so you could find the problems. And what I loved about it is it took that overwhelming feeling and it gave me my pathway to sit down and to make sure that I don't miss a single step. Dentists were notorious for shortcuts, right? And that's the longest way to get between here and the finish line. So, when you start doing these cases, simple, complex, variety of cases, the same way every time, you realize that you're building that pattern. I still use the checklist. I still use the wizard. I go through step by step by step, just as passionate as I did whenever I first started the program, because I want to make sure I don't miss something. And again, it was just freeing to me from that sense of just being overwhelmed and not knowing what to do or where to start.
Yeah. Well, the amazing thing about our checklist is that a lot of times we're faced with very complicated looking problems, but the way to predictably solve a complicated problem is to break it into its individual components, solve those one at a time in the correct sequence. And it's amazing how these complicated cases, they come together like puzzle pieces perfectly. And that's because you do it in a sequence that's habitual and predictable, and that you're doing it correctly to do that. And you don't jump around and skip around and miss things. And so what this really leads us to is what we call determination, verification, and communication. Because when we talk about this marriage of occlusion and function and aesthetics, one of the most important things that we have to do is we have to determine where do incisal edges go in space. Because a lot of times the incisal edges for our patients, they're in the wrong location. They're vertically and horizontally in the wrong position. A lot of times these patients have constricted envelopes of function and the anterior guidance is not correct. And so not only the maxillary incisal edge, but also the mandibular incisal edge, both of these have to be vertically and horizontally in the correct functional position to get the optimal aesthetics and to get the optimal phonetics. And then we have to utilize our provisionals as a source of verification, and more than that, quality control. And when we talk about controlling the quality, what I mean by that is our provisionals are not temporaries. They are provisionals that are there to actually test out our changes and to control the quality. Did we meet the aesthetic requirements of the patient? Did we solve the functional deficits that the patient was experiencing, and are they phonetically functioning in these teeth correctly? This is how we control quality, is by producing provisionals that are exquisite but also solve the job, but most importantly are the primary way that we communicate with our laboratory. Our provisionals have got to become the blueprints for our laboratory to change plastic into porcelain, or plastic into lithium disilicate, or plastic into zirconia. Whatever we're using, these provisionals need to become the absolute blueprint for our technicians to follow. And that is one of the absolute keys to predictability, and how we can sometimes do an entire full mouth rehabilitation and put all these units in and have them go in very predictably, where it doesn't have to be a very stressful event. And now, our communication, it's evolved over time. Now we do things digitally. We don't have to take impressions. Now we do digital impressions. And this actually sometimes makes this communication and the predictability through the communication actually sometimes even more predictable. So to kind of wrap things up, and then we'll answer your questions that you guys might have, I want to just really kind of highlight very quickly a patient. This is one of my patients named Susie. And if you look at Susie here, you can see that she has a lot of signs of instability. She's got wear into dentin. Her smile is becoming unesthetic. You can see that her lower mandibular anterior occlusal plane is starting to wear and become concave. And so all of these patients, we go through the same process of a complete examination. We do our additional records, and then we start to determine what do we do step by step through our two-dimensional treatment planning checklist. Where do we need to get these lower incisal edges? Where do we need to get the maxillary incisal edges to be both vertically and horizontally? And And what are these different photographs that we're taking and these different research rules that we kind of follow to guide us to determine where these teeth need to go in space to solve the aesthetic and also the phonetic and functional problems that these patients are tackling. And so this is what we teach at the Dawson Academy through our core curriculum, is we give you all this knowledge so that you can learn how to manage these cases very predictably and very profitably and very efficiently within your practice. And so all of this two-dimensional planning leads us into a three-dimensional treatment plan, which we start to restore the teeth on the articulator in models that are mounted in centric relation. And a lot of times we manage these cases with what we call reductive equilibration in the posterior and then additive equilibration in the anterior, which is basically restoring tooth, putting back tooth contours where they're supposed to be. That's what we call additive equilibration. We're adding back tooth structure that is missing for our patients. And then these produce our provisionals. Our provisionals then become our opportunity to control the quality, to make sure the patient's happy with the smile. Are they speaking well in the provisionals, and are they functionally working out well for the patients? And so we talk about these 21 photographs. We repeat these all 3 different times in our process. We do it preoperatively. I take these photographs again in my provisionals. These are provisionals that you see on the screen right now. And I want to make sure, am I getting the incisal edges and the shapes of the teeth, the golden proportion, my width to length ratios, is everything how I want it to be? And then my provisionals, they end up becoming how I communicate with the laboratory. So my laboratory will create custom incisal guide tables. They'll create incisal stents to make sure that those incisal edges are exactly where I had them in the provisionals. And that's how we can get these very beautiful, predictable aesthetic results for our patients, and how we can tackle these cases that can sometimes be very intimidating, because Susie's the kind of patient that can very easily break dentistry if we don't solve these functional problems and don't identify what was causing her to get in that problem in the first place. So we would really encourage you guys, if you like what you saw today and it's intriguing to you and you would like to gain predictability, and if you would like to have more confidence when you do these more extensive types of restorative cases, we would love to invite you guys to come and see Shannon, come and see Neeraj, come and see me at the Dawson Academy, and allow us to help to guide you through this process to make things more predictable. And so with that, I will stop sharing my screen, and we'll answer any questions that you guys might have. Are you there, Greg?
Yeah, lots of questions here. So let's dive right in, if you will.
Okay.
From Robin, how do you know if it's chemical or mechanical cause of loss of tooth structure? So chemical versus mechanical causes.
Well, when we look at somebody that's having the worn dentition, what we have to understand is a lot of times the worn dentition is a multifactorial issues that are all converging to get a patient to where they're in that static position in time. And so what you'll notice is when you really get trained on the worn dentition, that people that are having erosive types of problems from chemical, whether it's from bulimia or whether it's from GERD, you're going to see a specific type of presentation on the teeth. And then a lot of times when we see people that are having attrition-based issues or parafunctional types of issues that are being caused by centric relation, maximum intercuspation discrepancies, they're going to present in a different way as well. And so it would literally take me about an hour to answer that question effectively, but it is possible to learn how to accurately diagnose what the cause of the worn dentition that's you're facing with your patients.
Okay, this one, I absolutely love this question because I hear it all the time. Is there such a thing as normal wear with aging? I have a lot of 70-year-olds who look like that. And she's referring to like your early anteriors with all the cracks and chips. We spend a lot of time replacing composites in the anterior zone. So
I think, Lenny, if you don't mind, if I can take that.
Jump in.
I can't tell you all how many times I've heard a patient tell me when I meet them for the first time and I bring it to their attention, regardless of their age, has anybody talked to you about the wear that you've had on your teeth? And I'm telling you, 8 out of times they've been told it's a sign of aging. And I can tell you that there are people in their 60s and 70s who have a stable occlusion, who have minimal wear, if anything. And so I think there's a misnomer out there that it's a sign of aging. Yes, there's a possibility that teeth can wear for aging, but if you have occlusal stability, there's no need for excessive wear. And that's what you need to discern. Is it minimal wear or is it excessive wear? And I think once you understand the difference between the two, and it's age related, like Lenny said earlier tonight, a 28-year-old has lost half their dentition. Okay, that needs to be addressed. I look at it like periodontal disease. If you get diagnosed with period disease at earlier on in age, that becomes a bigger concern rather than getting diagnosed later on in life. And so that's how I would approach that.
Yeah, I want everybody to think about this. When you have patients that come in and their teeth are worn, and maybe it's somebody who's 45 years old, and the literature shows us that the average length of an unworn maxillary central incisor is 10.8 millimeters. And if you have a patient now that their central incisor is 7 millimeters long, I want you to think about the fact that this patient has lost nearly 40% of the length of their teeth. That's a lot. And and we see so many patients like this. The literature also tells us that the normal wear of a dentition is 10.7 microns per year, which is 0.000009 inches a year. That's 5 zeros in front of the 9. So normal attrition and wear in the dentition is almost negligible. And think about when you have somebody, think about a maxillary first molar. And when you have somebody think about that big, beefy mesiolingual cusp and how thick the enamel is on that cusp. And when you have people that have worn that cusp flat into dentin, it is a tremendous amount of wear that has occurred to get to that point. But we're just so accustomed to seeing it that we almost think that it's normal.
Okay. I hope Perry was paying attention because you just answered Perry's question, asking the distinguishing between occlusal disease and normal wear. So
okay, great.
So Perry, I hope you got that. Could you explain how occlusal disease affects orthodontic stability?
Well, that's a great question. That's a very loaded question. Well, the first way that the two are related and the two cause problems is that a lot of times orthodontists are moving the teeth with disregard to the position of the joint. And so we have a lot of patients that have discrepancies between their maximum intercuspation and centric relation. And make no mistake, every time your muscles of mastication contract, they're trying to seat your temporomandibular joint into centric relation, into the most axially stable, midmost braced position of your condyle. So that creates a problem. Another problem that gets created is that a lot of times our patients have worn teeth, and they want to a lot of times have orthodontics at the midpoint of their life, kind of a midlife crisis orthodontics, I call it. And so a lot of times the orthodontist won't really pay attention to how much tooth structure has been lost, and they'll simply move the teeth and move them to where they're still touching, and they'll move them into an unstable relationship where the teeth have been worn irregardless of centric relation. And then the third thing I'll say is that a lot of times, and I hate to bash our orthodontic friends, but a lot of times they like to leave our patients with anterior open bites. And it's amazing all the problems that patients experience when the front teeth can't touch properly. When the front teeth can't do their job, it creates so many problems with occlusal instability, muscle instability, and joint instability as well. And I'll shut up there, and maybe if you guys want to.
I'll add one more if you don't mind. I think you hit the nail on the head. But a lot of orthodontics can also violate a concept that we talk about a lot at the academy called the neutral zone.
Yeah.
So teeth erupt into place based on like the balance between the outward pressure of the tongue and the inward pressure of the cheeks. And those muscles, way more complicated than that, but that's kind of where teeth come into play. And so an orthodontist might flare teeth out in an aspect or move them into a more aesthetically pleasing position, but that might violate somebody who has really tight lips. And so then the teeth get retracted back and then they start hitting, or vice versa. They start pulling teeth back to close spaces. You have airway and other postural things that the teeth actually want to be out front, because I find that a lot of patients come in or have ortho with diastema closures and things like that. And then, they relapse and go back to their position, and then they want you to just pull everything back again. So that's just another way.
Yeah, absolutely.
Can I just add one more thing if I can?
Please.
So Lenny brought up a great point, is that in ortho treatment, they're not taking the joint into consideration. And in many times, you're right, they do leave anterior teeth not coupling. So what Pete has taught us is that a stable occlusion starts with a stable joint position and it ends with anterior teeth touching. And if both of those things are missing in orthodontic care, that puts you in a very bad situation to figure out how to fix that occlusion. And I just want to leave it as that, because it makes
Well
sense.
said.
Yeah.
Jobs of the front teeth are to take care and protect the back teeth, right? I mean, so if they don't touch to start with, and then the jaw seat further, well said.
So I'm gonna group a couple of questions here because it's on the same topic.
Okay.
It's how do you determine, and I know this is not an easy answer, it's coming up. How do you determine the ideal vertical dimension of occlusion?
Well, so that's a great one, and that it would take us a long time to answer. But
next week's webinar, maybe we can.
Yeah. What everybody needs to realize is that vertical dimension is not as complicated as we were made to believe in dental school. Vertical dimension really happens at the level of the joint, and vertical dimension is a function of the repeated contractural length of the muscles of mastication. And so most of our patients, they don't lose vertical dimension over their lifetime. A lot of times we think that when people have worn teeth that they've lost vertical, and now we need to crack open the vertical to solve the problem for patients to get restorative room. The short answer for this, because it would take too long to really go into it, is that centric relation is the eighth wonder of the world, and centric relation and being able to predictably record centric relation and to predictably treatment plan from centric relation is a lot of times the missing link that takes away all these problems and confusions with vertical dimension.
So, Neeraj, I'm going to throw this one to you.
Sure.
How do you communicate with patients about treatment plan for acceptance? I assume the patients do not expect to have full mouth rehab when they come in. Also, patient would not want to spend a long time to complete the case. So,
can we do this next Wednesday?
Right. So I think if you go to the blog, you'll see, and you do a search, and you just covered this.
So the communication part is something I struggled with, but I'll give you the really short answer. If you recognize occlusal disease, your job then is to make your patient aware of it. Whether they want to solve that problem or not, it's up to them. But as far as how to communicate them, as far as, forget about full mouth rehabilitation. I want to just make sure that we're all clear on this. Because you understand complete dentistry doesn't mean that every case becomes a complete full mouth rehabilitation. Now, if you equilibrate a patient's occlusion, that in itself is like a full mouth rehabilitation, but you got to understand that there are signs of instability, and your job now is to let your patient know. The job then is, does the patient feel it's an important part in their life right now to take care of this? Then the debate is, did you do a good job explaining the implications of not treating occlusal disease? And so I kind of will just leave it as that, but communication is everything. And I wish I could, I'll do a webinar on communication again, if it helps, but that's the best way I can answer.
Well, you do it really well. Can I add something to that, Lenny?
Yeah.
Is that all right?
Go ahead.
Well, I think in the question, you said something that's also very telling about dentists. We assume things about patients, when I really would challenge you to say, can we assume that about any patient? If patients aren't informed, if we as a profession have not really helped patients understand their problems, and going back to the implication mindset, what are the consequences of, real consequences of not proceeding with treatment, and what the options are, you know, we've done the patient a disservice, but we haven't given them the opportunity to choose care. We've already decided for them before giving them that opportunity. So really try not to assume things. Just open the conversation with patients in that co-diagnostic exam, establishing a relationship with the patient and caring for them. And, you know, Lenny, I love when you talk about just expressing genuine concern for a patient and where they are, because when it really does come from you and it doesn't seem like it's a bottom line and you have no skin in the game about case acceptance, you know, when you're really like, I'm here to help you. This is what I see going on. This is what it's going to look like in 5 years, 10 years. A lot of patients choose health. You know, Dr. Dawson would always say that patients, when given the opportunity, they will always choose to have a healthy mouth, right? I really actually believe that, you know. Now there might be some barriers that are in the way of getting them there, and it's our job to help them decide on the dentistry that they need at that time and how we can get them to a better place. But yeah, don't assume. That's my big thing.
Very, very well said, Shannon.
Tim, you asked a question about how do you prefer to get a CR record if the patient is partially edentulous, missing anterior teeth, preventing the use of a Lucia jig. Lenny, do you want to tackle that, or can we?
Yeah, well, yeah. I mean, there are times when you can't use a Lucia jig, and that's when you need to be confident and make sure that you've been trained properly in how to do bimanual manipulation correctly. You know, I practiced dentistry and took SAR bite records for 12 years before we had Lucia jigs. But yeah, sometimes you can't use a Lucia jig, or you got to use your bimanual. Yeah.
Yeah, and I'm going to throw one other thing in there again, if I may. Sometimes with people who are missing teeth, we think Dalar wax or Dinar wax is going to get and capture everything, and it doesn't. Sometimes you need an occlusion rim, and I will remind you that there's something called like a Gothic arch tracing, which we do for dentures, that with partially edentulous patients, it can work for you sometimes. So anyway, just throwing it out there, let your brain stew on it for a while. So
Great, and that will pretty much.
Good. Greg, you want to throw up our promo slide?
Yes, sir. So near and dear to my heart, I'm the only patient in the room, but I've sat through Seminar 1, Functional Occlusion, for years. And as a patient, it's great to see the light bulbs go off on dentists as they unravel all the mysteries and the light bulbs going off. So we're getting rid of the Zoom fatigue, and we're doing this back in person in Orlando this June. And for joining us here tonight, we're offering $100 off. Use the coupon code Florida100 when you go to our website, DawsonAcademy.com/seminar1. We'll keep that going until Friday. So don't tell your friends, just keep it to yourself. And we hope to see you in Orlando.
Yeah. Throw your family in an airplane, get down, take them to Disney while you do your course, and get back out and live a little bit.
Yeah, I mean, and not to like undersell or oversell or whatever, but I mean, literally, this is a life-changing event, which is why it's so great to like not do it over the internet, but actually do it in person, because there's always lots of questions, and our faculty will be there. They'll be available for questions and answers. And there's a lot of knowledge and a lot of hugging, and it's okay. It's
yeah,
okay.
everybody learns from one another. It's like, you just have a lot of energy in the room, and a lot of people start realizing that we're all in the same place starting, that we have all of these sorts of cases. And then when you start realizing that you can solve those problems and you feel the energy in the room, like getting excited about it is just really fun.
Yeah.
Well, we've at the Dawson Academy over the years, we've had tens of thousands of dentists that have graduated from the Academy, and they all start with this class. And it's amazing when we see the changes that have happened in people's professional lives, but through the professional change, what has been able to happen in their personal lives as well is amazing. And it all starts with Seminar 1, our Functional Occlusion Introduction Problem Solving. Hope to see you guys there. We thank you for attending and listening to us tonight, and we hope everybody have a safe rest of your week.
Thank you all. Good night.
Thank you, everyone.
Be well.
Thanks,
Bye.
Neeraj. Good
Bye,
night,
everybody.